we screened women for snoring and gasping and witnessed apnea, so where they stop breathing at night. And about a third of women actually snored loudly. Every pregnancy ends with a procedure. So it ends with labor and delivery, and sometimes with a surgery like a C-section. So knowing whether someone is at risk or has sleep apnea when they are going into this is important at any point in time. But pregnant women also gain fluid, like quite a bit of fluid during the course of pregnancy. And fluid can redistribute at night and might impact your upper airway as well.
Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Alison Kole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same.
Hello, everyone, and welcome back. I have a really unique topic. It's never been talked about on the show. And quite frankly, I think it's underrepresented in media, which is what happens when us ladies are pregnant and we're just really, our sleep has fallen off the rails. When do we have to actually be worried about a medical condition called obstructive sleep apnea? Obstructive sleep apnea affects women and men, and in fact, can leave our pregnant patients that much more vulnerable. So I'm bringing on a true expert in the field. This is Dr. Ghada Bourjeily. I met her at the WAVE conference and we really hit it off. She is just an amazing wealth of information. Ghada, I'm so excited to have you today. Her background is that she's a pulmonologist as well as a sleep researcher. She is a professor of medicine at the Warren Alpert Medical School at Brown University. She is the director of women's research at Brown University Health in Providence, Rhode Island. Her clinical and research expertise focuses on lung disease and sleep disordered breathing in pregnancy from preconception through the postpartum period and how these conditions affect both maternal health and babies' outcomes. She has led and contributed to many of the key studies linking sleep apnea in pregnancy with complications like high blood pressure, preeclampsia, gestational diabetes, fetal growth concerns, and she lectures nationally and internationally. And in fact, I quoted some of her research in my presentation, and I was like, oh, the lady who wrote this research is going to be on the panel. This is crazy. So welcome to the show, Ghada. I'm so excited to have you here.
I am so happy to be here. This is so fun.
So just a background question for you. How did you get interested in the topic of sleep and lung disease, and specifically the pregnant population?
The pregnant population thing, it started as a personal experience. It was my own pregnancy. I had completed fellowship and then something, I'm not going to go into details, but something was not right. And then I learned about this area in medicine where people study medical problems in pregnancy. So I'm not trained as an OBGYN. I'm trained in internal medicine. So I started learning about it. So it went from this personal experience to this intellectual curiosity because there was really nothing in the literature about it. At the time, there was very little that was known. So I became very curious to learn more about it and educate more about it. And then it became a passion and a privilege to help people get through their pregnancy when they have complicated respiratory and then celebrate with them. You know, they come with their babies and we enjoy that part. So there's something very rewarding about it now. So I love it.
I'm so glad that you were doing this research, and we're going to highlight by the end of this episode. So everybody needs to stick around and listen to this because everybody knows somebody who's going to have a baby or had a baby or had, challenges, right? That's the reality of the situation. It's far more dangerous than we think to go through and be able to carry a baby to term.
Absolutely.
In terms of when we're talking about sleep apnea, a lot of people have heard that term and a lot of people kind of realize, hey, I've heard that's like when you're not breathing properly at night and you may be choking, you may be tired, etc. When you think about sleep during pregnancy, what are some of the common issues you see? And are there certain tip-offs that a patient may actually be dealing with sleep apnea and be pregnant?
Yeah, so sleep apnea and some of the symptoms of sleep apnea are actually more common than you would think in the pregnant population. When we first started studying this over a decade ago now, we screened women for snoring and gasping and, witnessed apnea, so where they stop breathing at night. And about a third of women actually snored loudly and more than 3 to 4 days a week, so frequently. So snoring is a common symptom of sleep apnea. It doesn't mean that every snorer meets criteria for sleep apnea, but snoring is quite common. And when it's happening and it's happening frequently, or someone can hear it from outside the room, that is something that is definitely worth bringing up to an obstetric provider or a primary care provider so that the person can get tested and treated and managed appropriately. And if someone tells a pregnant person that they're not breathing at night or they have these pauses in their breathing, that's also not a normal thing that would happen. So I would say if you have any of these symptoms, definitely talk to someone about it. So breathing pauses, snoring excessively or loudly, even being sleepy, like some sleepiness is normal in pregnancy early on, and later on in pregnancy, women get to be sleepy for various reasons, including hormones, etc. But if it's excessive, if you're having trouble driving, you feel like you're going to fall asleep if you're driving, or, if waiting in a waiting room or something, these are not normal. Like, these are things that you definitely need to bring up to your provider.
Are there certain things that are happening physiologically that may tip someone? Do you have patients, for example, that maybe didn't have a lot of the symptoms of sleep apnea pre-pregnancy and then develop them later? Is there something intrinsic pathophysiologically going on, biologically going on, that leads the airway to be at more compromise during pregnancy? Can you speak to some of kind of the science behind that?
Yeah, so there are multiple factors that would hypothetically predispose someone to developing sleep apnea in pregnancy, or to having pre-existing sleep apnea potentially get worse in pregnancy. We all know pregnant women gain weight during the course of the pregnancy, not so much early, but later on in most pregnancies. So weight gain is important. But more important than that is where the weight gain happens. So weight gain happens in the middle. So when that happens, it leads to the muscles that help you breathe being a little bit elevated. Your lung capacity becomes reduced, especially when you go back and you lay in a position. But pregnant women also gain fluid, like quite a bit of fluid during the course of pregnancy. And fluid can redistribute at night from like your legs and your hands and everything into the rest of your body, and might impact your upper airway as well. And then another thing is that protein levels in your blood, so we call it oncotic pressure, tend to go down in pregnancy. So that means that there's more shifts of fluid that may happen. So just like women feel like their hands are more swollen, they can't wear a ring because it doesn't fit anymore during pregnancy, similar things happen around their breathing tubes and their upper airway. And a lot of these things may predispose to the development of sleep apnea. We don't know in which populations one of these things is more important, but these are things that normally happen. Plus, there's also some nasal stuffiness that happens because of hormones as well, and that can impact how patent and open the airway is. So many of these factors contribute to it.
Are there any patients that if an OB is seeing them, even if it's very early in the pregnancy, even if they haven't necessarily complained about sleep apnea symptoms prior to that pregnancy, are there certain patient characteristics that if there's a provider listening who may be seeing these people early on, that should be a flag for them to get screened sooner rather than later?
That's a really good question. So the data point, so about 2 years ago, 2.5 years ago or so, we published a guideline with the Society of Anesthesia and Sleep Medicine in obstetrics and gynecology. And it reviewed who would we screen, when would we screen people, and which specific population, or should we screen every pregnant person? I think screening all pregnant people is probably an overkill. people that are at a higher risk for developing sleep apnea or having sleep apnea in pregnancy are women with a higher body mass index. So if they meet criteria for obesity, especially the higher classes of obesity, but a BMI of over 30 would be one risk factor. And I would say those individuals would need to be screened for sleep apnea. And then people that have a prior history of either high blood pressure or they have high blood pressure when they're pregnant, people that have a history of diabetes or a prior history of gestational diabetes or preeclampsia in a prior pregnancy, because there is so much of an association between sleep apnea and some of these conditions, it would make sense to screen people with these conditions for sleep apnea. And then the time for when to screen people in pregnancy, that's a little more debatable. Ideally, if we could rewrite the books and we're not adding too much to the prenatal care and the how much people have to do and have to get tested for in the course of pregnancy, I would say it's best to screen them at each individual trimester. So screen them early for any pre-existing sleep apnea if they meet these criteria. But if they don't meet criteria in early pregnancy, they may still develop it later in pregnancy. So we would need to examine them again. And when exactly, I think we need to examine them at a point where we still can make an impact in terms of treating them. So if they need to be treated, we could still implement treatment, but also in a way that they've been exposed to pregnancy physiology long enough to now be at risk. So if we screen them too early, they may not have had all these pregnancy changes. If we screen them too late, they would have had the pregnancy changes, but we may not have enough time to treat them and make a difference if we wanted to make a difference. So screening at multiple points, and even if it is with a simple question like, do you snore? And if yes, how loudly and how often do you snore? And if people meet that question, especially if they have some of these risk factors, then refer them to be studied and to see if they have a diagnosis of sleep apnea.
Besides body mass index, is there anything else or any typical patient populations that you think may be more vulnerable? Ethnicities, for example, anything that you've seen a trend in the literature that we should be aware of?
Yeah, so the data in the pregnant population isn't as good as it is outside of the pregnancy, but there are some data in pregnancy. So we know that Black women may be at a higher risk for having either more severe sleep apnea or being diagnosed with it. There are some data in pregnancy, some analyses of specific cohorts. So this is a population that I would pay more attention to in particular, where I would think about it a little bit more. But we have to also consider factors that may impact, some of this risk as well, and make sure that whatever we are offering, we can offer and have it accessible to many of the populations that may be at risk, that we need to consider a little more carefully as well.
When you say be able to offer them, are you talking about access?
Yes, access to the treatment and access to even testing. And we know that, testing in pregnancy and treatment, it's not as easy for every insurance company and for every plan that covers pregnancy specifically. For instance, there are some plans that may not cover chronic conditions. These are things that we struggle with.
Wow. So there are people that even if you wanted to help them, it would ultimately fall on them as an out-of-pocket cost because they may not actually have any of that coverage.
Yeah. And that is unfortunate. In some states, it might be easier where women are covered during pregnancy and for a certain period after the pregnancy ends, but they may lose coverage after that. And in other places, and it really depends on the states, the coverage may not even occur in pregnancy if it is some chronic condition that had not been covered prior to that.
Is this in particular folks that may be on Medicaid, for example? Is that a factor, or are you even referring to even private insurances doing this too?
So private insurance is not so much of a problem, but more, state and more public insurances. These are the populations that we struggle a little bit more with, more on a national basis. Like in Rhode Island, I think we do a decent job, I think, in that I don't remember not being able to cover someone, but sometimes the cost of treatment, if I'm offering them treatment, might be high. So then we have to think about creative ways to get them treated and to provide them with, the management and the therapies that they need.
Do you have any idea how many people, once they get through pregnancy, does their sleep apnea resolve? Do they need treatment kind of forever? Or do you have any data on that about whether or not it might go away?
Yeah, this is a really good question. So there are a few studies that have been done, not our own, but sleep apnea seems to get better in most people in pregnancy, but it only seems to go away in about half of the women. So it may persist later, but that also depends on whether they had pre-sleep apnea prior to pregnancy or whether they developed it in pregnancy, but also like when they were tested, how much weight had they lost after they were tested? Did the weight get lost in the right places or not? Because, an increased weight is not the same. It depends on where the weight sits in your body, right? So it depends on individuals. So we don't know who the people are that no longer have sleep apnea in pregnancy once they deliver and who continues to have it. But what I would think is that the more severe your sleep apnea is during pregnancy, the less likely you are to lose it completely once you deliver. And if you've had it prior to pregnancy, likely will continue to have it as pregnancy ends and you deliver. So the way I think about this is that I have every person that have sleep apnea follow up with me after pregnancy. So I see them about 4 to 6 months after they deliver. And then we revisit their symptoms. We revisit their weight, whether they have high blood pressure, whether they have diabetes, etc. And we talk about their symptoms. And depending on that, we make a decision to repeat the sleep study and then see if they still have it or not. And in the meantime, I continue to treat them because once they have delivered, now sleep is even more precious, right? Because there are all these interruptions that happen with the baby at night. So every hour of sleep is really precious. So we definitely need them to have good sleep when they have it and it's so interrupted. So I continue them on treatment and then I have them follow up a few months later. And then, we have a discussion about what their risk for persistent sleep apnea is. And then we make a plan accordingly.
But this is very interesting and important, valid information because people need to know that once you are diagnosed, that there should be some follow-up in a way that's meaningful. And perhaps a CPAP unit or wherever else you're getting your sleep apnea treated is a temporary phenomenon for you. But perhaps if it's more serious than that, it would be a good idea for you to continue treatment. Very, very important info.
Yeah, don't take it for granted that it will go away. It needs to be reassessed and then evaluated because sleep apnea is associated with long-term outcomes. So we want to make sure that we are protecting these young individuals from having long-term complications later in life.
And there are some actual immediate complications potentially during the pregnancy if someone has untreated obstructive sleep apnea and it really hasn't been addressed. Can you speak to some of the things that women who are expecting need to understand about what could happen with them or even to their baby if we kind of ignore this and they have symptoms of sleep apnea?
Yeah, so sleep apnea has been associated with a few complications in pregnancy. You had mentioned earlier hypertension and preeclampsia. This is one important outcome that we and other researchers are focused on because it is one of the main causes for severe maternal morbidity and maternal mortality around the world. So it's an important thing to try to reduce the risk of and try to prevent if we can. So in many studies and across the United States in like population studies and outside of the world, the association between sleep apnea and preeclampsia has been demonstrated repeatedly. So, and even after we adjust for other risk factors like age and body mass index, et cetera, that association seems to be independent. And then there's also an association with gestational diabetes, which is diabetes that is first diagnosed in the course of pregnancy. So we know outside of pregnancy, there is an association with type 2 diabetes, for instance, but in pregnancy, so even that short-term exposure leads to an association with gestational diabetes. And these are things that are really important because outside of sleep apnea leading to or being associated with long-term complications, for instance, these complications that happen in pregnancy are also a preview of future maternal health. So preeclampsia by itself increases the risk for long-term cardiovascular disease and chronic hypertension. Gestational diabetes increases the risk for type 2 diabetes later in life. So these are things that although they happen in pregnancy and you may get tested after pregnancy and blood pressure is no longer there like 6 or 8 weeks after, and gestational diabetes is gone after you have delivered. But the fact that these things have happened increases your risk for long-term outcomes. So it's really important to think about things that are risk factors for these things and try to reduce them. And this is where I think sleep apnea and sleep disordered breathing fall, because they can help us hopefully prevent some of these complications and improve not just maternal health, but also long-term health. And then similarly with the baby, because with sleep apnea, there are these drops in oxygen level, your brain kind of wakes up every time that happens. There's an elevated inflammation milieu that happens as well. These things that might lead to abnormal placental function or so the placenta, which is the main organ that delivers nutrients and oxygen to the baby and everything, it may get impacted, and that might impact the baby as well. So some of the things that have been studied include preterm birth, for instance. So moms that have sleep apnea or even snoring may be at risk for delivering preterm. Growth abnormalities may occur as well, and those have been described. And both reduced growth, so growth restriction, but also growth acceleration has been described. And that depends on the person that has sleep apnea, because we all know that sleep apnea is not the same in everyone. And when we think about sleep apnea and comorbidities, so someone that has sleep apnea and diabetes might have different baby complications than someone who has sleep apnea but does not have diabetes, or someone that has sleep apnea and has developed preeclampsia, for instance. So there are like these types of complications that have been described in association with sleep apnea that make it even more important for us to think about it and consider it. The caveat here is that we don't yet know if we treat sleep apnea, can we prevent these maternal complications, or can we prevent some of these fetal and neonatal complications? So these are things that we're still examining. There are some emerging data that are very promising that we may be able to reduce preeclampsia or blood pressure numbers, but we need some additional studies in various populations so we can make sure that this is a generalizable finding and it's applicable to everyone.
Your messaging is so powerful and so important. We're gonna try to summarize now so I don't take up all of your time, though I could talk to you for hours. When we're thinking about from the provider perspective, if you could wave a magic wand and make sure that every single OBGYN PCP is out there asking their patients, their pregnant patients, questions, what would be the key sort of sleep questions you would want them to incorporate pretty standard as part of their workup and their visit?
I have to be realistic in terms of what could be accomplishable and what is a dream thing. So I think adding a question about loud, frequent snoring, so a snoring question with a follow-up about how loud or how frequent, doesn't add up too much to the prenatal care. and it can provide some really important information. So if we can do this at 3 time points in pregnancy, that would be really ideal. If we could do it early in pregnancy, at some point in mid-pregnancy, and then early in the 3rd trimester. Because one thing that I didn't touch on is that even if we diagnose sleep apnea later in pregnancy and we don't have time to start them on CPAP to get full benefit, it's still really important to know whether someone has it or not, because every pregnancy ends with a procedure. So it ends with labor and delivery, and sometimes with a surgery like a C-section. So knowing whether someone is at risk or has sleep apnea when they are going into this is important at any point in time. So that's why I think it's really important to think about it. But, if we're like thinking of perfect and fantasy world, it would be wonderful to even think about these things before a woman gets pregnant, because if we can intervene and make some modifications before the baby starts developing and before, the placenta is forming and everything, and then we create this environment where women are healthy when they're starting the pregnancy, maybe they could lose a few pounds. Maybe we could do some interventions that we may not be able to do in the course of pregnancy before they get pregnant. Then when the pregnancy starts, they are at their ideal, health status in a way, and then they can carry on the pregnancy in a more healthy way.
And one more question. This one is asking about your thoughts related to the ladies in the audience who may be thinking about getting pregnant or are pregnant. What are a few practical steps pregnant women can take today to protect their sleep and potentially lower their risk for sleep disordered breathing?
So many of the things are difficult to prevent in terms of sleep disordered breathing. But I think some things may be helpful in that if you are overweight or have obesity to start with, then stick to the recommended weight increase. And in order to do that, we're not going to get into the science of obesity and how complicated that is, but some general recommendations in pregnancy would be, eating a healthy diet, a diet that, has a lot of fiber or, something like that. I'm not going to, again, get into that, but sticking to the recommendations about weight gain is important. But some general things that are really important in pregnancy and that in a way, overlap a little bit with sleep apnea, but may not be directly related to it, is that it's important to follow a good sleep hygiene. And I can't stress that enough. We see this in pregnant women where they're busy doing a million things and then their sleep is restricted. They don't sleep enough hours in the night. And they're also a little bit uncomfortable because of, some of the pregnancy physiology, but they do have some habits that they have probably carried on from prior to pregnancy. And they're, on their phones late at night, they're watching TV late at night, their light exposure is not great. So there are some things that I think are really important for pregnant women to stick to in terms of good sleep hygiene, going to bed at the same time and waking up at the same time, and not going to bed one night at 8 p.m. and the next night at midnight or something like that. So a lot of these factors may actually influence the health of the pregnancy. So if you can follow some of these things, follow some good diet and weight gain recommendations, and then report it if you have symptoms of sleep apnea, advocate for yourself. If you are snoring, tell your doctors to do that, because that may not be part of the questions that, people get in prenatal care. But if you advocate for yourself and you mention that, then you can discuss options with your doctors and they can refer you to the right people that can help you manage it.
Fantastic. So as we finish up, we must definitely take some time to talk about where your research is right now and your call to action for my audience. So I'm going to turn it over to you. What do you need from us?
That's great. I would say whether it's our research or someone else's, I would urge people to participate in research. For the most part, researchers mean well and they want to answer the appropriate questions. And we want to answer the right and appropriate questions for all of our populations. But if someone does not participate in research, or if, populations don't participate in research, we don't learn as much about them. And then we're going to provide them with recommendations that may not be applicable to them and their, and their culture and their environment and their experiences, etc. So I would urge people to participate in research when you can and when you think it's something that you can do, because this is how we can advance science and this is how we can take better care of our populations. And then, so for our own research, we are currently recruiting for Black women, and we want to study the interaction between stress, sleep, and diet. So we have an ongoing grant that is funded by the American Academy of Sleep Medicine, where we would love to recruit women. We follow them longitudinally. We monitor their sleep for about 2 weeks at a time with a ring. We ask them about their diet and ask them about their momentary stress experience. And we would be very happy to include people that meet our criteria. So if that is a possibility, then, please feel free to contact us. And I'm happy to provide contact information as well.
Perfect. So I believe Ghada is going to be providing me with a QR code and a website, I guess, that takes you to the website. The QR code takes you to a website.
Exactly. Or it takes you to contact info.
Where you can read about the trial. Okay. This is not a trial that is trying a different medication, or this is really just collecting information that otherwise is like a black hole. Nobody knows what's going on.
Exactly.
So this is trying to acquire the information in a way that's really observational, not an intervention where you're getting randomized or not getting a treatment or getting a treatment. It's different than what you might be thinking of. And this is the type of thing, this is how we learn. And there's so much about sleep medicine, especially that in non-pregnant patients that we have learned from this type of observational data.
Absolutely.
So you will be able to find this QR code at askthesleepmd.com and hint, wink, wink. It will also be featured in the YouTube video, and I'm going to be doing some social media posts to try to get the buzz out, because the reality is that our women of color are truly, truly underrepresented. Women in general underrepresented in research, women of color even more so. There are a lot of historical reasons why that occurs and a lot of mistrust within the medical community. I don't know if it means squat to anybody listening, but I can tell you that if you're going to be part of Ghada's study, you're going to be truly respected and the scientific method will be adhered to. She truly cares about your well-being. And that's why she's volunteering her time to come on the show. So thank you very much, Ghada. It is a pleasure. And I really appreciate you and what you're doing.
Thank you very much for having me. This was a lot of fun, and I hope that it can help some people. So,
me too. Thank you.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com, and while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.